What is cystatin C? Cystatin C is a low molecular weight protein, 12.8 kilodaltons, produced by all nucleated cells. It acts as a cysteine protease inhibitor, playing a role in various physiological processes. Why is it important? Serum cystatin C is an excellent marker for estimating glomerular filtration rate, GFR, making it vital for assessing kidney function. Gene regulation. The gene for cystatin C has a housekeeping-type promoter with no major regulatory elements. While initially thought to have a constant release into circulation, recent research suggests otherwise. Factors affecting cystatin C levels. Influences on production. Production is influenced by thyroid hormone levels, obesity, diabetes, cigarette smoking, C-reactive protein and white cell count. It is inversely correlated with serum albumin. Unlike creatinine, production is not significantly impacted by muscle mass. Other influences on serum levels. Levels vary with age, gender, pregnancy, weight, and height. Age and gender adjustments are included in some GFR estimating equations. Genetic factors. Genetics can independently affect cystatin C levels, although their impact on chronic kidney disease, CKD, classification is modest. Renal clearance of cystatin C. Cystatin C is eliminated exclusively through the kidneys, with no extrarenal clearance pathways. Due to its small size and high isoelectric point, 9.2, it is freely filtered at the glomerulus. Completely resorbed and broken down in renal tubules, resulting in low urinary levels. Clinical significance of urinary cystatin C. Elevated urinary cystatin C levels are a marker of renal tubular damage. Analytical methods for measuring cystatin C. Historical techniques. Early methods like immunodiffusion and rocket electroimmunoassays are obsolete. These methods laid the groundwork for modern immunoassays. Current immunoassay techniques. Widely used methods include particle-enhanced turbidimetric immunoassays, nephelometric immunoassays. These are compatible with automated chemistry analyzers or dedicated nephelometers. Precision and performance. Assay imprecision ranges from 3% to 6% near the upper reference limit, 1.00 mg per liter, and improves at higher levels, less than 3%. Precision improvements are essential due to the within-subject biological variation, CVI 5%. Advantages of immunoassays. Minimal interference compared to traditional creatinine assays. However, reagent costs are higher than creatinine-based assays. Emerging technologies. New point-of-care devices using sandwich immunoassays with monoclonal antibodies are under development. Reference intervals and gender-age variations. Gender and age variations. Cystatin C concentrations are generally higher in males than females. Levels naturally increase with age, often surpassing young adult values by over 50% in the elderly. This age-related rise aligns with the typical decline in GFR as we age. Challenges with population reference intervals. A single reference interval for the entire population can mask age-related declines in renal function. Accurate baselines require a well-defined reference population with verified kidney health. Cystatin C in infants. Levels in infants are naturally higher, starting about 50% above adult values during the first year of life before gradually decreasing. In preterm infants, concentrations are even more elevated. Reference interval standards. For young adults, ages 23 to 50, a reference interval of 0.6 to 1.1 mg per liter is considered reasonable. Biological variability, CVI. Understanding CVI. Serum cystatin C biological variability in healthy individuals ranges from 4.5% to 8.6%, with a typical value of 5% as per the RICOS database. Clinical significance. This low variability makes cystatin C a stable and reliable biomarker for GFR estimation, with minimal external influence. Clinical utility and GFR estimation. Cystatin C as a GFR marker. Produced at a constant rate, cystatin C is freely filtered by the glomerulus and not reabsorbed or secreted intact in the proximal tubule. Its serum concentration directly reflects GFR, providing a robust indicator of kidney function. Superiority over creatinine. Studies, starting with Kaisanderson and colleagues, demonstrated cystatin C superiority to creatinine in detecting kidney disease. This has been consistently supported by numerous studies and meta-analyses. GFR estimation equations. Cystatin C-based equations calculate GFR by correlating levels inversely with renal filtration. KDIGO recommendations and emerging equations. KDIGO endorsements, 2012. The CKD-PI cystatin C equation, CKD-PICs, was recommended for standardized cystatin C results. KDIGO also endorsed the combined CKD-PI equation using both creatinine and cystatin C, CKD-PI. Pediatric-specific combined equations are available for younger populations. Emerging GFR estimation equations. Kappa equation, a simple, adaptable formula without race or gender adjustments. BIS-2 equation, combines creatinine and cystatin C, focusing on elderly populations. An alternative approach involves estimating GFR separately using creatinine and cystatin C to detect potential interferences. Laboratory and clinical collaboration. The role of laboratories and nephrologists. Collaborative efforts are essential to determine the most suitable GFR estimation equation. Decisions are guided by clinical evidence, assay quality, and patient-specific factors. Biochemistry and physiology of urea. Composition and role. Urea's molecular weight is 60 daltons. It is the primary nitrogenous waste product of protein catabolism. It accounts for over 75% of non-protein nitrogen excreted by the body. Production via the urea cycle. Urea is synthesized in the liver through the urea cycle, involving intermediates like aspartate and ammonia. Its production reflects the rate of protein catabolism, which depends on dietary protein intake and endogenous protein breakdown, primarily from muscle tissue. Distribution in the body. Urea diffuses freely through cell membranes, distributing evenly in total body water. Its volume of distribution equals total body water. Excretion pathways. Over 90% of urea is excreted by the kidneys. Minor amounts are lost through the gastrointestinal tract and skin. Renal handling and relationship with protein catabolism. Renal handling of urea. Urea is freely filtered at the glomerulus and passively reabsorbed in the renal tubules. The extent of reabsorption depends on urine flow rate. High flow states, e.g., pregnancy-reduced reabsorption. Low flow states, e.g., reduced GFR increased reabsorption, leading to higher plasma urea levels. Urine concentration. Urea is highly concentrated in urine, where it reaches 20 to 100 times the plasma concentration. It's a major contributor to urine osmolality. Protein catabolism relationship. Daily urinary urea excretion directly correlates with urea production and reflects the rate of protein breakdown. Role in kidney function. Specific urea transporters, regulated by vasopressin, influence kidney function and urine concentration. Urea plays a complex role in maintaining the kidney's concentrating ability. Analytical methods for urea measurement. Chemical and enzymatic methods. Chemical methods. Early techniques used direct reactions with urea but have been replaced by enzymatic methods. Enzymatic methods. Urea is hydrolyzed by urease, producing ammonium ion, which is then quantified. Enzymatic approaches in detail. Spectrophotometric methods. Measure ammonium using the Berthelot reaction or an enzymatic assay with glutamate dehydrogenase. Commonly applied in serum assays, monitoring absorbance changes at 340 nanometers. Coupled enzyme systems. Urease generates ammonia, leading to a series of reactions that produce a measurable dye or other end products. Alternative approaches. Use of leucine dehydrogenase alongside urease to eliminate interference from endogenous ammonium. Dry chemistry and conductimetric methods. Dry chemistry systems use urease with various detection methods. Conductimetric methods measure conductivity changes as urea converts to ionic species. Potentiometric methods utilize ammonium ion selective electrodes with immobilized urease membranes. Performance, specificity, and traceability. Performance and specificity. Enzymatic methods, particularly urease glutamate dehydrogenase, offer high specificity. Precision. Within run CVs, less than 3%. Between day CVs, less than 4% for concentrations of 14 to 20 mg per deciliters, 5 to 7 millimoles per liter. Interference. Endogenous ammonia can interfere, particularly in aged samples or certain metabolic disorders. Traceability and reference standards. Reference methods. Based on isotope dilution mass spectrometry, IDMS, ensuring accuracy and standardization. Reference materials. Pure and matrix-matched materials are available for calibration. Routine assays generally show biases of 10% or less, though certain methods exhibit statistically significant differences. Reference intervals and biological variability. Gender and age differences. Men tend to have higher serum urea levels than women. Serum urea increases with age, with the upper reference limit rising by about 50% from the 20s to the 70s, reflecting the decline in renal function. Pregnancy lowers serum urea due to glomerular hyperfiltration. Population and dietary influences. Variations in serum urea concentrations across populations often reflect differences in dietary protein intake. Pediatric trends. After the first 2 weeks of life, serum urea levels are low during the first year. Levels peak slightly above adult concentrations by age 10 before stabilizing to adult values in the late teens. Reference intervals. Healthy adults, 2.1 to 7.1 millimoles per liter, or 6 to 20 milligrams per deciliter as urea nitrogen. Adults over 60, 2.9 to 8.2 millimoles per liter, or 8 to 23 milligrams per deciliter. These intervals vary based on age, gender, diet, and population, requiring careful interpretation. Impact of specific intervals. Using age, gender, and population-specific reference intervals improves the sensitivity to detect disease-related changes in serum urea. Terminology and units. The term blood urea nitrogen, BUN, is outdated, as urea is measured in serum, not blood nitrogen. Conversion tip, 1 mg per deciliter BUN equals 0.357 millimole per liter urea, SI units. Urinary urea excretion. On a typical protein diet, 12 to 20 grams per day, or 430 to 710 millimole per day, of urea nitrogen is excreted in the urine. Biological variation, CVI. Serum urea CVI, 12%. 24-hour urinary urea excretion CVI, 18%. Clinical significance of urea levels. Kidney function assessment. Historically, urea was used to assess kidney function but is less reliable than creatinine. Serum and urinary urea are still useful in specific scenarios, such as dialysis adequacy evaluation. Factors influencing urea levels. 1. Increased urea production. High protein diet. Increased protein catabolism, e.g., burns, trauma. Gastrointestinal bleeding, reabsorption of protein. Corticosteroid therapy. 2. Reduced urea removal. Prerenal causes, reduced renal perfusion. Renal causes, intrinsic kidney disease. Postrenal causes, obstructive uropathy. Urea to creatinine ratio. A critical tool for differentiating prerenal azotemia from intrinsic renal causes. Normal ratio, 49 to 81 millimole urea per millimole creatinine, or 12 to 20 milligrams urea per milligrams creatinine. Elevated ratio, greater than 81 millimole per millimole suggests prerenal azotemia, often due to reduced renal perfusion. In acute kidney injury, aka a high ratio is linked to increased in-hospital mortality. Clinical conditions impacting urea levels. Chronic heart failure. Increased urea levels and an elevated urea to creatinine ratio are poor prognostic indicators. This is often due to neurohormonal activation. Pneumonia risk stratification. Urea is a component of the CURB-65 score, confusion, urea, respiratory rate, blood pressure, and age greater than 65. Low urea levels. Seen in conditions such as low protein intake, as in starvation, anorexia nervosa. End-stage liver disease, due to impaired urea synthesis. Limitations and advanced applications of urea. Limitations of urea clearance. Urea clearance underestimates GFR due to tubular back diffusion. Using the average of urea and creatinine clearance for GFR estimation is no longer recommended. Urinary urea measurement. Provides a basic estimate of nitrogen balance. Useful for guiding protein replacement in patients receiving parenteral nutrition.